The black really picks up.
And let's go live on YouTube with the Auburn Medical Group YouTube show.
Yes.
Talking about
Asthma.
Okay.
Can you wheeze for me? Take a wheeze for me. Oh, there you go. I can kind
How much of that is actually bronchial and how much of it is
it's
the glottis?
Upper airway.
Yeah. What was mine? You can still hear mine after, like a 10K run or 10-mile run.
Oh, sure. Yeah.
Yeah. But no asthma symptoms. So a lot of people watching probably have asthma or family members or children with asthma. And
very common.
Got a lot to talk about here.
Sure.
And it's getting more common.
Right.
Yeah. So we're going to jump right into that. Let's talk about that. But first. Let's see. We had comments.
Okay.
What was the comment? I just read it to you before you came in here.
Which one? Oh, on our soda show?
Oh, we had comments on the soda show. That's right. That's right. Soda
comments?
was our show.
The soda show.
I'm trying to think. Did I have soda since the last show? I
have not. I can very easily say
I have had that mocha in the Keurig machine, though, which is probably just as bad.
I have some sweetener in my coffee.
Yeah.
I've had some LaCroix. LaCroix.
Yeah.
I've had a few of those.
And then we also didn't address, we just talked about soda on the last show. We didn't talk about coffee and tea.
Oh, you're right.
I don't come down hard on coffee by itself as long as somebody doesn't have their blood pressure elevated by it.
Right.
I also don't come down hard on tea.
Arrhythmia may not be.
Yeah, if somebody has an arrhythmia or has high blood pressure or...
Yeah, not the best choice.
Yeah.
Maybe
then we
half
want
calf or decaf.
Yeah. Yeah, I'd say so.
Laura Spurs and Bianca, both members of our channel, say hi.
Oh, yes, members. Channel. That's the other thing, channel membership. So before we jump into asthma, we want to remind our viewers that they can become members of the channel by hitting the little join button. And if you can't find it, you can go into the description and go down a little bit, you'll find a way to click on a link to become a member of the channel. And why do they want to be a member? You'll probably want to watch a little video that shows what you get for it, but you can get these icons so we know immediately when we look at the chat that it's you.
Yes.
That is a good thing. And there's some other things that other people will get if you want to go at higher levels, like having your name mentioned, like Lindsay Antwine and...
Well, Boo Boo Kitty and Teresa Roa for my...
on your channel?
Yeah, on my channel.
But we certainly
Patreon,
do give extra attention to the people who have that little
we do appreciate
badge. Because
we always accept
the channel.
Super chats if you're so inclined. Super
chats can make for an interesting show. We haven't had one since we added the special effects. So if you do the super chat, you'll certainly get attention. Not only from us, but also from the people watching.
Yep.
So that would cover just the things I wanted to cover before we jumped into asthma with Dr. Gawain.
It's with me. Where would you like to start?
Well,
what do we know about asthma? Who gets asthma?
We should say what asthma is. We should talk about the increasing rates of asthma.
Yeah.
And we should talk about treatment, including asthma action plans. Those are the things I'd want to cover.
That sounds about right.
If you have something you want to make sure we get to, please send a message right now through the chat so we can make sure to address that. And of course, if anybody is a channel member or super chat, they will really get us. And we always have, I guess almost always have the phone available. There's a phone number you can call your voice will come right over the show and people will hear you watching on YouTube Live. If you happen to be watching this not live, but after the fact, going through our library of programming and finding that you're wanting to learn about asthma, if you want to catch these shows while they're live, make sure you're subscribed to the channel and hit the little bell icon so you'll get notifications. And then you can participate in the chat.
Yes, absolutely. Somebody says, "Wait, you have a channel?" Well, good news. You're on our channel. So that's how YouTube
Auburn Medical
works.
Group channel.
It's the Auburn Medical Group channel.
Yes, we do have a channel.
That was also Isabel who said something very nice early. She said, "This is the only good thing about her Mondays."
That's Isabel. Thank you. Yeah, that was kind of before we even got going, wasn't it?
Yeah.
Okay.
So what is asthma?
Well,
asthma is a type of obstructive lung disease. Let's start there.
Not restrictive.
Not restrictive.
I always thought it was restrictive.
Why?
Because the they're restricting the airflow. The bronchioles get dilated, and obstructive would be from something kind of closing from the outside, like COPD, where you have the architecture of the lung kind of losing its support, and so the airways get blocked by something from outside of them instead of restriction inside.
What?
Of the airway.
It is an obstructive lung disease.
Okay.
You confused me there. Restrictive means you can't fully extend.
Okay.
So restriction. Yeah, like scarring of the lungs or pulmonary fibrosis.
Okay.
Some other things. But yeah, it's in the asthma is like COPD. It is an obstructive. So the obstruction comes when you try to exhale and your airways are tight. So you can't exhale or get the air out as quickly as you're supposed to.
Because there's an obstruction.
Because there's an obstruction of the air coming out. And so the hallmark thing about asthma is it's reversible.
That's cool.
Yeah, so we can fix it pretty quickly, typically with a bronchodilator, which we'll talk more about the treatments, but that's like albuterol. I'm sure you've heard of that before. So that's asthma in a nutshell. It's, I guess, inflammation.
What are some other names for albuterol they may be more familiar with?
ProAir, Ventolin. There's another name brand. Strangely enough, there's no generic albuterol. Their only name brand. Good job.
Isn't that weird?
Pharmaceutical companies.
How did they manage that?
I have no idea.
I think it has to do with changing the propellant.
Rebranding.
In the last 12 years.
Yeah, that's what it is, yeah.
I think that's what it is.
Yeah, no more CFCs or whatever.
So you got the, there's a third one, and I can't come up with it either.
Yeah, Ventolin, ProAir, and Proventolin. Is that what it is?
Ventil, ProAir, Ventolin.
ProAir. Ventolin. Yeah, something like that. Anyways, there's 3 of them.
Okay.
They're all albuterol.
Yeah.
They all do the same thing. And then there's a newer one called Xopenex, which is levoalbuterol, which they've isolated the active form of the albuterol, and it's supposed to have less cardiac side effects.
I think there's another levoalbuterol.
There may be, but the Xopenex is the one that I've used. And it's
So
much more expensive,
as much,
and usually it's not that big of an improvement over the regular stuff.
Unless you have a real problem with your heart just going into an arrhythmia with the albuterol.
Yep.
Use the cheap stuff.
So, obstructive lung disease that is reversible. There are different subtypes of asthma, like exercise-induced asthma, those who get it whenever they exercise, like jogging or working out. That's often brought on by cold air, too. There is the asthma, or not asthma, but allergy-induced asthma. That's often part of the atopic triad.
Which now I know what that is.
Yeah. So that is asthma, allergies, and eczema. If those 3 often go together. So if you have one, it's common to have one of those other ones, or both of them. And
sensitive people.
It's sensitive people.
Skin, airway.
Yeah.
Yeah.
What other types of asthma am I missing? Irritants in the air can bring it on, but that's just kind of general.
Did you say
smoke's a bad one?
Intrinsic?
Yeah. Intrinsic asthma, yeah. I did not say that.
Oh, I'm sorry.
Go ahead. Talk about intrinsic
asthma, where you don't need some kind of external stimulus to cause it. It just comes. You just have trouble breathing.
Yeah, yeah. And those are the ones they're doing a lot of new research on with these new leukotriene blocker antibodies, which we don't prescribe. Those are definitely a more specialized medication from a pulmonologist. But yeah, pretty amazing stuff they're doing there.
Okay.
Yeah. Risk factors. Smoke exposure. It's a big one. So if you smoke, stop.
Absolutely.
That will make your asthma worse and make you have more exacerbations. If your child has asthma, stop smoking. Please don't expose them to the secondhand smoke. Even if you're smoking outside, it still is getting to them. So don't do that. What else? Risk factors. Being overweight or obese. They used to think that it was just the extra weight, but now some new studies are saying that the adipose molecules actually release something we don't understand that worsens asthma. Okay. That was something I learned today. So interesting.
But it's hard to get moving and lose the weight if you can't breathe.
It's true. It's true. Yeah, so you got to get it under control. And the problem is often those people have more exacerbations, so they're treated with steroids, which
make you
more
add
overweight.
on more weight. Yeah.
So, other risk factors. That's kind of the big ones.
So you covered you talked about the, not Ventolin or ProAir, but, well, yeah, it was those. The albuterol that will work to reverse that constriction, opens up the airways right away.
Yeah, very quickly acting.
What are the other treatments?
Oh, so albuterol is the mainstay of treatment. It is a rescue inhaler. So that means when you're in the midst of, I can't breathe. I'm sure you've seen asthmatics where they're just like wheezing and they can't get the air out. That'll reverse that. So other treatments, there are some long-acting treatments which help. Well, I guess maybe we should distinguish stages of asthma before we talk about that, because long-term treatments are for people who have more what's called persistent asthma, or symptoms more often, so more than twice a week, or 2 nights a month that wake them. A daily medication is helpful, and it can be often daily if people have symptoms. Then you definitely need to do one of those long-term medications. So the long-term medications are in the form of mostly inhalers. There's one oral medication, but the inhalers include a long-acting beta agonists. Those are essentially long-acting albuterols, if you want to think of it that way.
And nowadays, they're almost always put in combination.
Yeah, and
with
they're
something else.
often in combination with a steroid.
We actually can't say names of brand names that you would ever hear of, because they don't come by themselves anymore.
Yeah, salmeterol, Ceravent is one of those, but I don't know. I can't think of the last time I've prescribed that, because I usually just do the combination therapy with a steroid. So the steroids are like, I can't think of the names of the actual ones, but like Advair, Dulera. What are some of the ones I'm thinking
So
of?
Advair is a combo.
Yeah, those are combos. And then there's steroid. Brio's another combo.
Trelegy is a triple.
3-in-1. It's a 3-in-1. That has also a LAMA, which is long-acting muscarinic agonist, which
we do know the brand names of.
Spiriva is the common one.
But we don't use that in asthma.
We don't. No. So Trelegy is not often used in asthma.
It's not really an asthma drug.
Yeah, it's more
but the
COPD.
Others are. The Advair and the Dulera.
Yeah, and sometimes
Symbicort.
you just need... Yeah, Symbicort, that's a good one. Sometimes you just need a steroid on its own. So there are a lot of inhalers that just have steroids.
Yes.
And that would be Qvar,
Flovent,
Pulmicort. I feel like we're playing a game. Who could name the most? No. Anyways, so there's this idea of step-up therapy where you go up to the point where your asthma is under control. There's one pill, and that is Montelukast or Singulair. Very helpful if you have a combination of asthma and allergies.
And there's a
Furlicast. Okay, I never use that one.
I don't know its brand name.
Okay, I was going to say I've never prescribed that. It's always Singular because it's generic.
That's probably because it's always in combination with those other ones we talked about.
So
the combo inhaler.
And that works really well on kids. I use that a lot, Singular on kids, those atopic kids who just have everything. And then steroids. So oral steroids are not recommended long-term because they go through your whole system and have some very unfortunate side effects. Like we said, weight gain,
and rarely
insomnia.
do you set asthma long-term.
Yeah, and then if you do it long-term, you can have really bad side effects like fractures, osteoporosis. Anyways, the list goes on. So those are only for when you're in an exacerbation, and we do a taper typically over the course of about 12 days.
So it's really to get you over an episode.
Get you out of it, essentially.
Takes days to get out of it.
And that's prednisone is the common name for that. I'm sure you've heard of that before.
Or Decadron, dextromethorphan.
Yeah, if you're in the hospital, they'll give it to you IV.
I'm sorry, not dextromethorphan.
That's a cough medication. Close. Decadron, though.
Thank you. That's what I was trying to go
is what you were saying. Let's see what people are saying here. So that's a quick
comments. So you look at the comments while
I'll do that.
Also mention.
I don't smoke anymore. Good job, Laura. Laura's commenting all over the place. Appreciate that.
Okay. She's a member.
Is there different inhalers for food? I don't understand that question. Oh, COPD. Autocorrect. Yes, there are different inhalers, like we said. That Trelegy is and more of those muscarinic agonists. They work a little differently. They're more long-acting, non-steroids.
What other member comments do we have there?
I'm on Arnuity. That's what Laura says. She's a and
sounds
ProAir for COPD.
Yeah, ProAir.
I don't know what Arnuity is. I've
heard it.
You've heard of that one? I've never prescribed it. It's a name brand. The problem is, okay, let's talk about the problem with these inhalers.
The problem?
The problem
The
with
price?
these, yeah, that's the problem. There's like no generic inhalers. So they are like, what, 300, 400 bucks? You saw one today that was 600 bucks?
Trilogy.
Trilogy, 600 bucks.
620 something.
Ridiculous. So sometimes, especially on people who have like Medicare, once they get to that donut hole and they're having to pay out of pocket, that's a lot of money.
Have I told the story before how this happened, how there's no generics?
Probably, but go ahead.
Okay.
Update the viewers.
So here's how it works. You make a medicine. You got 12 years of it to recoup your R&D costs, research and development, for those who don't know. 12 years to recoup those costs of what it took to develop that medicine before it goes generic, and anybody has the right to make that medicine, and they don't have to pay you licensing fees. So during that 12 years, you get all you can of it. Charge what you need to, because they do need to charge a certain amount, maybe not as much as they are, but they need to make a profit in order to stay in business. That's in the United States how it works, and other capitalist countries. Well, what's the word for it? The thing that makes it come out. The
Propellant?
Propellant. The propellant in these medicines, the chlorofluorocarbons, I believe it
That's
was.
what it used to be, yeah.
You're not allowed to use those anymore to propel the medicine out of the container. So a new propellant has to be used. Well, here's the thing. Even though the medicines were generic and the medicine hasn't been changed, with the change of the propellant, somehow the drug companies were able to get this considered a new drug with a new patent. Even though the drug hasn't changed, just the propellant. Go figure. So now there's no more CFC inhalers. They're all new propellants. And another 12 years of being able to charge hundreds of dollars for these medicines per month for the amount a person would use in a month.
Ridiculous, yeah.
So now we've got all of them non-generic, all of them name brand. Does that pretty much cover
That sounds
where I was
right.
wanting to get us to explain why these medicines cost so much across the board and we can't find an affordable one for people who don't have insurance that covers medicines?
Right. Yeah. Somebody brought up
and even if you do have
GoodRx.
insurance.
Somebody bought. And
use
we
GoodRx.
often use that.
Or singlecare.com.
These are ways to get some coupons that can bring down the cost if you are on some of those inhalers, and if you are, I'm sure you know about those costs.
Again, goodrx.com and singlecare.com to check it out. But you're still going to find that most of these things cost $400 a month.
Right.
Even with that.
It is ridiculous. So, try to work with your doctor. We always try to find the cheapest of those. It's still like $300 a month.
Yeah, sometimes you just keep going from one to the next to the next to the next. And you just don't find one that's affordable. And so essentially you have to kind of pretend they don't exist if the patient can't afford them.
Yeah.
And there's no other.
There's somebody on here who is on Dulera, and they brought up the GoodRx. They say they only pay $18 with their insurance and a coupon from GoodRx. So that's actually amazing.
Wait. Coupon and GoodRx?
That's what it says.
Can't use them both together.
Coupon and health insurance. Anyways, the coupon's from GoodRx. Anyways, I'm glad you're getting it for $18. That's amazing.
However you're doing. We're good. So, asthma action plan.
Yeah, let's talk about that.
So, asthma is this disease where you have exacerbations that occur. It gets really bad at times, and it's not going down with just the use of the inhaler. So, we have a standardized way of getting that taken care of. You can make your own asthma action plan using the link in our description. The state of Minnesota, came up with an interactive website that they made. So you can just put in your information. There's something called an FEV1, forced expiratory volume in 1 second, that you have to measure with something called spirometry or a pulmonary function test. You may not know that. You can actually mark that you don't know it and just go with the predicted for your height. Yeah, it's by height.
Height and weight, I thought.
Yeah, you put in both your height and your weight.
Yeah.
Don't worry, we're not looking. State of Minnesota is, but we're not.
It's all right.
And it'll help you through this. So what's it going to show us when we put in our height and weight and say, use the predicted FEV1 for me?
Right. So it gives you this plan. Actually, you printed one out here, which is kind of nice.
But we're not going to show you because it's somebody else's. We don't know if we have
protected
permission
health
from
data.
Minnesota.
Yeah.
Oh, yeah, it has my birth date on it, too.
It's got your
So there's
patient identifiers.
three steps to it.
Yeah. So, well, first thing is you need to have a peak flow meter.
Yes.
Yeah. That's and basically what that is, a little chamber you blow into, and it gives you a little readout of what your number is. What would that number be? Your
millimeters or cubic centimeters.
I don't know what that actually stands for, but it's going to give you a number.
Milliliters.
And based on that number, you can see where you're at. And we put you in zones. So there's a green zone, a yellow zone, and a red zone. So green zone's great. You know, you're right where you need to be. I think that's 90% or better of your, probably says on there, of where you should be.
So 80 to 100%.
80 to 100.
So if you're in the green zone, 80 to 100.
You're doing all right. And then that would be just normal use. So if you take a daily medication, you want to still continue to take your daily medication to keep you in the green zone. And then have your rescue inhaler for, if you're somebody who needs it prior to exercise, you still would do it prior to exercise, etc. So that's the green zone. If it falls beneath that from 50 to 80%, 50 to 79%, then you're in the yellow zone. And the yellow zone is just like a yellow light caution. Let's bump up treatment here, and you start using your inhaler. And you give your 2 puffs immediately right after you find that you're in that zone. And then you can repeat that if you're not back to the green zone in an hour. I believe that's how it goes.
In an hour. If not within an hour, then oral steroid medicine.
Yep. And then this one actually says if you're in it after 6 hours, then you should, or you're getting worse, then follow the red zone. And we'll talk about that, the red zone instructions. And the red zone is red, flashing, emergency. This is serious, below 50% of your lung function, essentially, how well you're getting the air out. And that's when you really want to start using, definitely get that inhaler going right then. And then you can, at that point, you usually want to go to the ER, go to urgent care, contact your provider, see a doctor quickly because your function's pretty low. Now, sometimes that ProAir will work and reverse some of that, but we don't want you down there for too long. So you still want to call your doctor, or go to the ER at that point. That's scary. And we don't want people down there. That's scary. Well, I was telling you a statistic earlier today.
Yeah.
Did you know that 11 people die from asthma every day in the United States?
Yeah.
11 people, that's the average. So that's scary. And it's usually not due to inability to treat the asthma. It's just not getting to services in time.
Yeah.
Yeah.
I've seen it.
Yeah, unfortunately.
It does. And here's the other thing you need to know is that as many patients die with mild to moderate asthma as severe asthma, it's the same disease process, just a matter of how tight those airways get. And it can happen to people with mild asthma, and that's why we have deaths from it. So we take it very serious, getting people encouraged to be on an asthma action plan. Now, if you have mild asthma,
Laura upgraded.
Welcome,
hey!
Laura. Laura, welcome.
She was already a member. Now she's a super member.
Yeah. Thank you, Laura.
Unfortunately, we can't see what you upgraded to, but we'll check that out later, and we'll give you a shout out.
We're interested.
For sure. We'll give you a shout out.
Inquiring minds want to know. So I was talking about how. What was I doing? Oh,
sorry.
The asthma action
we
plan.
interrupt for members.
We do. Members can interrupt. Or
Super chat.
Super chat. Yeah, that'd be another one. Or if you call on the phone because you're actually coming through on the audio.
Right, where you were talking.
Where was I talking about? I was talking about the
red zone emergencies.
People taking their medicines normally on the green zone. Sometimes for really, really mild asthma, like it doesn't happen for weeks or weeks or weeks, when you're not taking any medicine, you may not have maintenance medicine recommended. So go ahead and do the asthma action plan if you haven't done that with your doctor. Take it to your doctor, and what will happen is you'll be empowered to go ahead and treat your own asthma according to how you're doing on the peak flow meter to keep from having a problem. And doctors normally will actually prescribe prednisone for you to have on hand, or have the prescription at the pharmacy in case you were to go and dip down into the yellow zone and not come out of it.
Yep.
So be empowered.
Somebody was asking if the light was supposed to go off with a upgraded.
No, that's a super chat thing.
It's only a super chat.
We did it once, but we had to do it manually,
Okay.
and it was awkward and took time. That's the super chat.
Oh, now she says now it won't let me do your pictures. All right, that's right. The face emojis, just what we need.
It will let her?
No, she says now she can't. Anyways, we'll have to look into that.
Once she joins, she can't do the pictures?
Now that she upgraded, I don't know what
she still can. Yeah, you can do everything at the level below.
Okay, I don't know.
Yeah, I'll double check it though,
radio
but you're
testing.
supposed to be able to do everything everybody can do. And I'll fix that if it's not letting you do it because we want you to be able to do that. Thank you, Laura. That's cool. We like that you did that.
Quick question from Koro. Do you ever float the skinless zombie behind you over someone you know while they're sleeping? You mean Francis? I have not done that
we've
yet.
We've not yet done
But
that.
Thanks for the idea.
Yeah, that was interesting.
I'm going to have to sleep with one eye open now.
Yeah, really.
Gosh.
Wake up with them
You
right
too.
over you, face to face. Organs would fall out and
Probably.
wake you up.
That would, yeah. Yeah.
Francis doesn't stay together too well.
Yeah, she falls apart. He, she.
Well,
Currently a she.
Well, no. Wait,
A gender.
are you sure? Oh yeah.
I don't see.
the neuter Francis part is down there, and the male is over there, and the female's there. Yeah.
Do you
we
need
have options?
a prescription for a flow meter?
I don't know that you do.
You can get one at a pharmacy, I believe.
You can.
Sometimes
and we will write prescriptions for them
Yeah.
so they're covered through the
some
insurance.
offices have them. We
That's a
don't
good
have
question.
any, but yeah, you can get one at your pharmacy.
At your
I'll
pharmacy.
ask your doctor for one. He should be
Yeah,
able
they
to
charge a little bit for them. Oops.
set you up. Whoa.
I almost changed our. Yeah. So, anything
All right.
else on asthma?
Do we hit all the high points? Treatment,
We did. And we talked about
diagnosis,
asthma
action plans.
Oh,
Big
one thing we
questions
didn't
before you
cover.
go?
Why are we having so much more asthma? I
Great
hinted at that at the
question.
beginning. Do you have an answer?
Do I have an answer?
Is it pollution?
I've heard a lot of theories, and I don't know if any
do
of
we
them
have
are.
Anything definitive on that? A lot of people
I don't think so.
And
A lot of them allergies too, and that kind of
Yeah.
goes hand in hand with this.
I've heard some podcasts about children growing up in certain areas where everybody who grows up there seems to be getting asthma. I mean, that's an exaggeration, but
Right. Much
families
more
stuck
common.
there and can't move out of the area because of economic factors. And there are areas that are close to, I think it was petroleum industry, if I'm not mistaken.
I would think that any exposure early on could do that because your immune system is developing over those first 6 months. And if you're having some exposures at that point.
Yeah, families that before this generation had no known family history of it, and now all the kids are having it.
That reminds me, I was listening to a podcast and somebody was doing some research on why peanut allergies have gone up in the U.S.
Yeah, share with
And the
us.
funny thing is, in the U.S., the idea was, oh shoot, your immune system's developing. Let's not give you any peanuts until later on. And then unfortunately that didn't work, and we were seeing more peanut allergies. Over in the UK, shout out to our UK viewers, I guess you have this thing that everybody eats when they're young that has some peanuts in it, and babies that's like one of their first words, this little peanut thing, and they'd get it early on, and they have a much lower incidence of peanut allergies.
Interesting.
So what they were finding that because of this earlier thought, this science-based thought earlier on, that you shouldn't be giving it to kids earlier, they were actually getting more exposure through their skin and not through their digestive system of peanuts. And that was causing more peanut allergies. So now, give your kids peanuts early on. Not peanuts, but maybe some peanut butter-based stuff. Don't give them peanuts. Anyways, science is always changing. We're always learning new stuff.
So it's actually better to have the kids exposed
Earlier
to it
exposure, yeah.
food-wise,
yeah.
orally, rather
Yes,
than
by mouth,
skin.
not by skin. Yes.
Yeah,
exactly.
interesting.
Yeah.
We'll have to, I guess we'll see more data on that and see if that was actually the thing.
Oh, somebody says the cold makes their asthma flare. I think
Yes.
we mentioned that early on.
Yes, cold can be an
Yeah,
external
cover your mouth, wear a
stimulus.
mask when you're out in the cold. That's what
Yeah.
it does is just kind of startle those airways.
So-
I think we've answered all the questions.
I believe also
Hopefully.
the dry air is more of a problem
Yes.
than more humid air for exacerbating the asthma.
Yeah.
So humidified air helps. Okay, that's what we have for today. Again, thank you. Who was it that did it? Was it Deborah? Laura. Thank you, Laura.
Spurs.
The rest of you also are welcome to become channel members. The instructions are in the description, and you can follow the link. And also, you can follow that link for the State of Minnesota's interactive tool for doing your own asthma action plan. Get it all filled out, take it to your doctor, and they can help fill it in with you, or do it with your doctor so they can actually put the medicines in it as it's being made, so it's complete. Mine isn't complete because there's no medicines.
Yeah, if you have the medicines.
Yeah, you want to have the prednisone in there too.
And if you want a more in-depth dive into asthma, check out the blog. I got a nice in-depth.
That's right. There's a link.
Diagnosis spotlight there. There's a link in the description
to that
below.
specific post.
Perfect. Yeah,
Okay.
check it out. Before we go.
Yes, we want to thank Lindsay Antwine for her membership.
Yep, and I want to give a special shout out to Boo Boo Kitty. Heard from her earlier this week. She hasn't been participating as much, but I guess she's been going through some rough times. So our thoughts are with you. And also Teresa Roat, my other Patreon. We appreciate your support.
Thank you. And until next time,
Dr. Goyen Bond.
and Dr. Mark Vaughn telling you to stay in good health.